Submacular hemorrhage, it results either from a choroidal bleed or it results from abnormal retinal bleeds that come in. It is most commonly seen in case of neovascular age-related macular degeneration, or commonly in case of PCVs that we see. Now, the conditions which are associated with CMUM using, including myopia, trauma, ocular histoplasmosis, angiostrics, can also lead to submacular hemorrhage. Now, why is submacular hemorrhage so important? Okay. And why does it need an early treatment? The basic thing is there is a presence of iron, hemosiderin, and fibrin in the blood, which has got toxic effects on the photoreceptors. Even the blood clot that can retract can cause a shearing effect, which is a mechanical traction on the photoreceptors, thereby damaging them. And even the physical separation of the photoreceptors from the RP for a prolonged period of time due to a submacular hemorrhage, which may not be resolving over earlier, can cause a scar or damage to that particular area of photoreceptors. And since the mechanism of damage are time dependent, we actually need to have an early intervention in this case. Now, how do we classify it? The basic thing we have to understand that the thickness of the hemorrhage is more important than the size that we see as disc diameters. Because you can have a very small bleed, just about half a disc diameter at the fovea, which is very thick, which can damage the fovea more than a 3 or 4 disc diameters hemorrhage, which can actually just have a very thin submacular hemorrhage, and then that can be observed. It really does not need any active treatment because it may not damage the photoreceptors as much as a thick submacular hemorrhage. So the thickness is more important than the size, that I would say. Now, when you get a case of submacular hemorrhage, I think the most useful would be an ICG to know the site of the CNVM, because an ICG has an infrared camera which can penetrate through the hemorrhage and which can tell us about the choroidal pathology, if any, which is there. OCT is important because, like I said, it tells us the size and the location of the submacular hemorrhage, because if it is sub-RPE, then a surgical treatment may not work. But if it is subretinal, only then a subretinal surgical treatment can be attempted. Now, going to the management, we can either have the options of observation, anti-VEGF treatment, or displacing the blood with the help of intravitreal gas with or without TPA, or surgical displacement. Now, this is the case of a very mild bleed which was due to a lacquer crack, or if you have a trauma or a choroidal rupture with a mild submacular hemorrhage. Here you can just observe, and over a period of time, you can see the hemorrhage goes off without much damage to the photoreceptors. And this is a medium-sized submacular hemorrhage, which is thin. It is not very thick. It is from CNVM, and just by giving anti-VEGF agents, you can see that the hemorrhage has got cleared and the patient recovered a good amount of visual acuity. Now, when you have a thick submacular hemorrhage which is not going off easily, then you might have to do displacement. And the displacement can be done either just by gas, with or without TPA. Now, you can choose only to use gas, which is a very cheaper option, just office procedure. The only problem is it takes a longer time to displace because it takes time for the clot also to become liquid over a period of time. The complications, as usual, can be vitreous hemorrhage, endophthalmitis, or RD, which is associated with any injection of gas that is given inside the eye. So this is such patient in whom just a gas was given, and you can see that it displaced over a period of time. About 7 days time it took to displace, and the patient also has to maintain prone position for that much amount of time over a period of that many amount of days. Now, when you use TPA, the only advantage that you get is there is a faster displacement because the TPA will, of course, liquefy the clot. And like just a gas injection, even this is an office procedure with the complications remaining the same. Now, this is a fairly large submacular hemorrhage, and here just giving a gas wouldn't have worked. So I've given TPA and gas and given the prone position, and now you can see even this type of a thick gas could be displaced by a gas injection. Thick hemorrhage can be displaced just by a gas injection given along with a TPA. Now, if the thick macular hemorrhage is very thick and it is less than 3 weeks old, or you're just involved or just inferior to the fovea, then you can think of a pneumatic displacement. Because if the hemorrhage is above the macula, then there are chances that it will get displaced into the macular area further when you're trying to do this particular displacement. Now, what do you do when you have a very large submacular hemorrhage or a very large superior submacular hemorrhage, which can slowly migrate to the center of the fovea? There you can attempt a surgery. Now, here I usually like to do a vitrectomy with a subretinal TPA with Avastin and air, followed by a fluid gas exchange. Now, this is a case of a large submacular hemorrhage, and in whom I have done a vitrectomy and I've cleared off the macular area of all the membranes. And then this is a 41 gauge subretinal cannula through which I'm injecting subretinal TPA along with air and Avastin. So as you know, I will zoom down, you can see the bleb coming up. There, the bleb is coming up. Now, what happens if you give subretinal air is that you get a very large bleb. And when you get a large bleb, you have that much amount of space in which the liquefied blood can migrate to. And then basically what you do is just a half posterior chamber fluid gas exchange. That you can do by judging the depth of the flute needle that you're using for an FGE. Now, this is the needle that is used, and the main thing for doing a half FGE is that the upper half of your vitreous cavity is filled by gas, and the tamponading effect out there prevents this blood which gets liquefied from moving upwards, rather it moves downwards. So you can see this is the hemorrhage, and just 4 hours after the surgery, the gas is filling the upper half and it's preventing the blood from migrating upwards, and it actually pushes the hemorrhage down into the area which was expanded by the subretinal injection of TPA Avastin with air. And you can see that within 4 days, the most of the macula is clear and just a bit of hemorrhage left behind, and this patient has done extremely well. So there are two things that are important: a smooth injection without being rushing into the injection, injecting just the right quality of air to giving maximum expansion, and most importantly, doing a half fluid gas exchange so that you have a tamponade in the upper half of the retina, preventing the migration of the liquefied blood into the upper half. Of course, if you have a very large hemorrhage, then you have to go ahead and do a retinotomy on the side and approach the subretinal area, and the hemorrhage then can be taken out with the help of a cutter, and then you can settle the retina back after you remove most of the blood from the subretinal space. Sometimes if you see an associated CNVM with a scar, you can even remove that since you're anyway in the subretinal space, and follow it up by injecting PFCL, doing laser, and settling the retina. So to conclude, submacular hemorrhage is a potentially visually devastating condition, which is most commonly associated with CNVM. Given its poor natural course, various forms of treatment options have to be tried with variable success, but we have to treat it, because if you just leave it there, it's going to cause irreversible visual damage. We can try office-based procedures with or without TPA, and if there's a very large hemorrhage, then you can try a submacular surgery by injecting subretinal TPA and anti-VEGF agents. Thank you. Thank you very much for your patience listening. Thank Dr. Goa to include me in this IC, and thank you AIOC for giving us this opportunity.